looking for a PFO on a transthoracic echo is kind of like looking at a house at night with a flashlight. The advantage of TCD is that it's highly sensitive and non-invasive. You can literally train your 15-year-old kid to do this. About 15% of the patients were totally missed on transesophageal echo. In my son's generation of being a doctor is going to be unbelievable. Hard to predict.
You can't replace part of the brain. Like,
you treat them the same.
Source of truth for the medtech industry.
Coexists with the puppets.
Robot understands things automatically.
Number one show in the medtech industry.
So Stryker got ahead of that and changed in the $90 billion company. They had help up high, a lot of things.
State of medtech with your host, Omar M. Khatib.
Hey everybody, welcome to the stream. I'm so excited to see everybody. I know everybody's just rolling in right now, so get settled in. We'll be bringing in our speaker shortly. I'm really excited for today's session. Here over, first of all, in the state of medtech, we love highlighting not only like exciting new technologies, but more importantly, clinicians who have a really strong vision for what the future can hold, not only for medicine, but for, patients, and just taking really new and innovative ways of solving really big problems. Today, we're going to be talking about how robotic TCD is reshaping stroke and PFO pathways. And I'm going to bring on stage a gentleman that actually I've known about. I met him for the first time earlier, but I've actually known about for a while since we did our very first State of Stroke webinar a few years ago on the show. And that's Dr. Thomas Devlin. So Dr. Thomas Devlin is a nationally recognized stroke neurologist and a clinical researcher for over two decades of experience in the cerebrovascular care space. He serves as the executive medical director of CHI Memorial Stroke and Neuroscience Center and is the lead enroller of a multi-center bubble study, which was recently published in Stroke 2023, which compares robotic transcranial Doppler or TCD to transthoracic echocardiography, TTE, for advancing non-invasive stroke diagnostics and integrating robotic TCD into both neurology and cardiology practice. So let me bring him on to the stage. Dr. Devlin.
Thank you for allowing me to join you tonight.
Absolutely. It's my pleasure. Thank you for joining in. So that being said, let me bring on the stage, Dr. Devlin, your presentation. And Dr. Devlin, I'm going to take myself out, but I'll be in the backstage area if you need me, okay?
Thank you so much, Omar. Appreciate it. Well, thank you, everyone, for joining us this evening. I want to talk about a topic that I think is very, very important, near and dear to my heart, how robotic TCD is reshaping stroke and PFO pathways. I am a certified vascular neurologist, and my role, I'm the stroke director here in Chattanooga, but much more importantly, I'm the medical director of National Common Spirit. So Common Spirit is something people may not know about. We're actually the second largest healthcare system in the entire United States behind HCA. Hospitals everywhere from the West Coast to the East Coast, including Barrows Neurologic Center, Baylor College of Medicine, Creighton, and a whole bunch of hospitals on the West Coast all the way to the East Coast. And my job is responsible for looking at technologies all over and vetting them both clinically very closely and then financially very closely. We've changed the world a couple times, a group of stroke neurologists over the years. We did it first with the launching of the interventional therapies. We had the good fortune to be the lead center in the world in that. Then we had the fortune to be the first center in the world ever to use AI for stroke detection with the AI algorithms. I really feel like what we're talking about tonight is really going to be the third chapter in that amazing story. And that's around robotic transcranial Doppler. And I want to give you my perspective on this. Let's talk about a typical patient that I see. I do a lot of stroke patients. I see a lot of stroke patients, take care of patients all ages. Here's a young girl having a very big stroke. She has a left MCA. I'm sure many of you have seen this scenario many, many times.
Valerie, I want you to tell me, what is your name? Okay, so she can't speak. She's aphasic. Valerie, close your eyes. Close your eyes. Open your eyes. She's able to follow commands. Big smile. Show me your teeth. Big smile. Show me your teeth. She's very weak. Big smile. Show me your teeth like this. Good. She's very weak on the right face. Let's take a look at your arms, Valerie. Raise this arm up. Good. Raise this arm up here. She has a left gaze preference, and she's very weak. She's essentially paralyzed in that right arm. Okay. Can you raise this leg here for me? Raise this leg. Good. Raise this leg for me here. Okay. She's paralyzed in the right leg. Good stuff.
So we actually took her for a thrombectomy, and she had a clot removed from her left M1. And about 3 days later, that's what she looked like on the right. And we had the good fortune, this was as intervention was getting started, we had the good fortune to introduce her to somebody who stopped by, who saw her story. And this is what he said. Omar did not recognize this person, but here's the audio of what he said.
It was really interesting. A couple of docs showed us, some stroke recovery procedures. And one of the examples was a 26-year-old woman who got a stroke and she couldn't talk. And then the next film they put up there was her talking and how happy she was. And it had to make you feel great, Doc, to know that you saved somebody's life. And so I thank you.
Now, I was disappointed in Omar because Omar is from Texas.
All right. I'm going to jump in. I got to jump in. I think I know who it is. Can I try a guess?
Yes, please do. Please do.
Former President George Bush.
That's exactly right. So that was George Bush. Thank you. Very good. You've redeemed yourself. So
all right, great. I'm jumping back out now.
He started the story of this young girl, and it was all about the intervention and how great that was. But as he was leaving, he turned to me and said, but why, Dr. Devlin, did she have a stroke at her young age of 26? And the very embarrassing thing is I had no idea, because we had worked her up top to bottom and she had multiple echocardiograms. And this is what we saw repeatedly, that she had a negative bubble study, normal EF. We monitored her for a long time, negative hypercoagulable state, no other risk factors, did a very deep dive, no answers. And this has been part of my practice as a conundrum for many, many years. I've had many, many patients like this. A few years after that, Robotic TCD came by. We did a TCD on her. And what we found was that, in fact, she had a Spencer grade 4 PFO. Typical findings on the left MCA, you can see there, the right MCA. And then here you see when we inject bubbles in the left wrist, that she had a whole flurry of bubbles end up in the middle cerebral artery territory. So this was, and then many of these patients like her go on to have their PFO closed. Now, I don't need to tell this audience that there is a wealth of data now on PFO closure. We have RESPECT, we have REDUCE, we have CLOSE a number of years ago that showed significant relative risk reductions in properly selected patients. And the Skylines every couple of years now have come out with very clear indications on who to close and who not to close. And those indications and the age at which we'll consider closing people is actually getting much broader. So where do we live? Here is where we live. If you look at what the frequency of different stroke etiologies are by age of the patient, and you look at AFib versus PFO versus dissection or other causes, you can see that the older you are, the more likely it is that atrial fibrillation caused your embolic stroke. The older you are, the less likely it is that a PFO caused your stroke. We know that about a quarter of the patient population walking around the street today has a PFO. It's even higher in the population of patients that have had a stroke. But if you look at where we live, we typically live in this box. Even up to age 60 or older, a significant number of patients may actually have the stroke due to their PFO, as you can see. So we live in the intersection between this AFib line and the PFO line. The critical thing is you definitely don't want to close somebody's PFO and then find out 3 months, 6 months later that they have AFib. So you definitely need to work these people up quite thoroughly. But we are frequently considering the PFO as a possibility at the same time that we are looking for atrial fibrillation. It's tricky because on average, how many days does it take of continuing monitoring to find AFib? We know from Crystal AF that's about 84 days on average of monitoring to find atrial fibrillation in a cryptogenic stroke patient. So, but the PFO always has to be on your mind. And if you don't find it, you cannot properly adjudicate it in the workup on the cryptogenic stroke patient. Now, when you go back and you look at all of the studies done on sensitivity, specificities of these different technologies, very nice study was done, which was a big meta-analysis published in 2016, 35 studies, over 3,000 patients. And they showed we have some real challenges around transthoracic echo. Now, we always start with a transthoracic echo. We'll get into that in a second. But if you look at this published meta-analysis, the sensitivity of transthoracic echo itself is not particularly high, only 45%. TCD is actually much higher. And if you look at specificities, while specificities may be good, the concern is you cannot afford to be missing PFOs on patients with transthoracic echo. And why is it low? Well, I usually explain to patients that while we start with a transthoracic echo, critical to know, what is their ejection fraction? Is there a major wall motion abnormality? Is there something else that can be causing an emboli? Do they have a big atrial myxoma, etc.? Looking for a PFO on a transthoracic echo is kind of like looking at a house at night with a flashlight through a picket fence, because the bubbles are going in 3 different directions in the atrium, which is a fairly large chamber. They are obscured by the breast tissue, they're obscured by the ribs, and that can be very problematic. On TCD, when the emboli come out of the left atrium, go into the ventricle, it's a straight shot up to the brain. They usually end up in the MCA territory, okay, on the left and the right, but they all line up like little soldiers coming directly towards the TCD probe, towards the temple, in a very narrow middle cerebral artery, only a couple millimeters in diameter, all directly towards the probe. So it's not surprising that the sensitivity of TCD is much better. So the advantages of transthoracic echo, to start with, it's certainly frontline diagnostic. You have to rule out other embolic sources. It's widely available. The disadvantages, as we mentioned, is poor sensitivity. The advantage of transesophageal echo is that it is the best visualization of the intraatrial septum. Now, that is going to be absolutely critical, because at the end of the day, when you're evaluating for, is the PFO related to your stroke, you're going to want to calculate a Pascal score, which is a combination of what is the Rope scale score and are there high-risk features of the PFO, namely, is there an intraatrial septum and how big is the PFO? And the transesophageal echo is the best at assessing the presence of an intraatrial septal aneurysm. The disadvantages are that it's invasive, and it's really not at all particularly great or sensitive at finding the PFO. And why is that? Because the patient typically cannot Valsalva, because they're sedated and they have a tube down their throat, and it makes it very difficult. Even pushing on their abdomen is not particularly effective as a Valsalva. The advantage of TCD is that it's highly sensitive and non-invasive. The disadvantages into regular TCD is that it is very operator dependent. It takes a lot of skill and a lot of training to do manual TCDs, and it can be difficult sometimes to know if you're looking at a pulmonary shunt or a cardiac shunt. So thus emerges robotic transcranial Doppler, which itself is a non-invasive technology. It's highly accurate at detecting right to left shunts, which is critical for preventing secondary strokes, because it's very, very good at helping identify a potential PFO. It's very good at overcoming the constraints of conventional manual TCD, because number one, it allows for simultaneous bilateral monitoring for emboli. The windowing is very, very good. We do a much better job at getting MCA flow windows with the robotic, much better than the handheld. It's fully automated, and you really need essentially no training in ultrasound in order to use the robotic TCD. And excellent detection algorithms for emboli, bubbles, etc. And we really love the data presentation that it gives us and the app that allows us to review all the studies and generate reports. And our ultrasound techs in our Echo Lab absolutely love the touchscreen, the way it works. They really like it a great deal. Those are the benefits of the automated robotic TCD. Now, let's get into some of the data. So we became very interested in, as we rolled out robotic TCD, really how good is it, and is there an opportunity to improve on our current protocols for PFO detection? So the first thing we did was we did an industry-sponsored trial called the Bubble Trial. And this was a multi-center, prospective, single-arm, not non-significant risk study comparing the robotic-assisted TCD to standard of care transthoracic echo, simply looking for right to left shunt and PFO. We looked at patients that were 18 years or older with an apparent embolic stroke or a high-risk TIA. There was 5 centers, as you can see on the right there. The original publication of the methodology was in 2021. We published the results in 2023. And what we found was pretty alarming. The NG2 robotic system detected 3 times the number of large shunts, Spencer grade 3, 4, and 5, compared to transthoracic echo. In addition, transthoracic echo missed 2/3 of the large shunts. So not only did we see a lot more shunts, 300% more shunts, but we saw shunts that were large, not just small shunts, but large shunts. So transthoracic echo undersized a lot of these and missed a whole lot of them entirely. In addition, in the Bubble trial, we also compared manual TCD with the robotic TCD, and we found that the robotic TCD greatly outperformed manual TCD by about 2 times more overall right to left shunts were detected. So here's a great example. Here's an echo. The bubbles are administered. We detect absolutely no bubbles in the left atrium in this patient. Then on the same day, we follow that up with a robotic TCD, and you'll see the little white lines here, which are hits, which stands for high intensity transients. These are bubbles being captured on the left side and on the right side in the middle cerebral artery. Very, very clear. And it's very easy to quantitate this. This was a grade 5 PFO. We used the Spencer grading with grades 3, 4, and 5 considered large PFOs. So when we published the data, what we didn't know was that the editors took a very careful look at the study, and at the same time that the publication came out, they wrote Larry Wexler, very famous stroke neurologist, to write an editorial. And what he said was, underscoring what they thought the significance of the paper was, he said the automation of the TCD embolus detection represents a significant advance, but real-world experience is needed with this device beyond a few medical centers with enthusiastic providers in a study environment will be helpful to confirm its utility. So what he's asking for is a non-industry study with more patients to validate it. And he was exactly right, and that's exactly what we did. So representing the second largest healthcare system in the United States wanting to roll out new technology, I said at the beginning, we look at 2 things. What is the clinical data, And what do the finances look like? I hate to say that, but in this day and age, no margin, no mission. So we're really focused on what is the clinical data. And up to this point, there was a lot of single center studies. There was multi-center meta-analyses, but we wanted to collect our own real world data. So we started with our own center and we set up a QI study, which was called Bubble QI. This was a single center study at our center here in Chattanooga, right in the heart of the stroke belt, where we compared robotic TCD versus transthoracic echo for right to left shunt and PFO in patients with high-risk TIA and stroke. And this was actually even larger numbers of patients, 148 patients, than the original Bubble study, with the mean age of 58 years old. And what we found was very interesting. So robotic TCD showed a significant increase in right to left shunt at a rate of 60.1% versus 37.2% with transthoracic echo, resulting in a p-value of less than 0.001. So overall, looking at all shunts detected, that's a 1.6 times increase of all shunt detected for TCD over transthoracic echo. When we specifically looked at Spencer grade 3, 4, and 5, the number actually went up. So robotic TCD had a 1.9 times increase in right to left shunt detection over transthoracic echo. Now, the Bubble study showed 3 times. We show 1.6 and 1.9. 1.6 and 1.9 is still a very, very large increase. Why was our number a little less? Clearly, we think that's because we have really, really, really good ultrasound echo techs that do a really good job and work very hard to try to find PFOs on transthoracic echo. So what we're uncovered here is that echo, just like manual TCD, is very tech dependent on the ability to detect PFOs. But even in our center with a huge cardiac program here, we still greatly outstrip our PFO detection with robotic TCD rather than echo. We followed that study up then with a larger multi-center study, again, independent study, validating what we found almost exactly in our Bubble QI study, which was they found overall shunt detection of 1.7 times over transthoracic echo. What was interesting in this study is they looked at the comparison of TCD versus transesophageal echo, and very alarming and not surprising and consistent with previous literature, about 15% of the patients were totally missed on transesophageal echo, but found to be positive on TCD. So we miss them on transthoracic, we miss them on transesophageal echo as well. We'll pull all of this together here in just a second. But these results, if you go back and you look at the multi-center studies that we did, our independent studies, Bubble QI, our original Bubble study, the findings are very consistent with many published studies over the last 10 years, showing superiority of RATCD over transthoracic and transesophageal echo. So with that, we wrote a national protocol for all cryptogenic stroke. And what we put right in the middle of this is a very critical area for robotic transcranial Doppler. So based on the data that we have at hand now, which is quite a bit of clinical data, we do believe that transcranial Doppler fits in the overall cryptogenic stroke protocol. And let me show you exactly the protocol that we now adopt for PFO detection. If PFO is of clinical concern, okay, for example, because of an elevated Robe score, then you always start with a transthoracic echo with a bubble study. And why do you do that? Because one, you have to look for other causes of embolic source. Do they have an atrial myxoma? Do they have a very hypoplastic ventricle? Do they have a very low EF? Do they have endocarditis, et cetera, et cetera? So you start with that. If you find a large PFO on that, you don't need to do a TCD. But if you find a small or no PFO, then you go over to the robotic TCD. If you found the large PFO on transthoracic echo, then you do the transesophageal echo next, simply because you want to get a good look at the anatomy of the PFO, particularly whether or not there's a septal aneurysm. If it's positive for PFO on transesophageal echo, then with your Rope scale score, with the size of the PFO, which you know is going to be large, and with the anatomy of the septum to see if there's an atrial aneurysm there, you can determine the Pascal score. And with Pascal, you're going to grade it as either unlikely, possible, or probable that the PFO caused the stroke. That's what Pascal tells you. Now, if on the transthoracic echo it's negative or small, you do your TCD, and it's positive for right to left shunt, then you go to the transesophageal echo. Now, if the transesophageal echo is positive, then you just continue down here, because now you're going to know the size very accurately with the TCD, because you're going to know how many bubbles were up in the head, and you can do your Spencer grading, and you can look at the anatomy for septal aneurysm, and you have your Robe scale score, so you'll be able to do your Pascal score. However, sometimes we'll have a negative transthoracic echo, we'll have a positive TCD, and you do your TEE here, but it's negative. Well, if the TEE is negative, but you're still highly suspicious that there's a PFO because you had a very positive TCD, then what do? That's when you want to go to ICE, and you want to consider doing intracardiac echocardiography, and you will actually go in mechanically into the atrium and actually probe the septum with the device and see whether or not we can find it, or if we can see it with intracardiac echo. Then if ICE is positive and we know there's a PFO, then we're back to do the Pascal score. If the Pascal score shows unlikely, and of course you're doing this having ruled out and fully adjudicated for atrial fibrillation, hypercoagulable state, vasculitis, and the 20 other reasons, and then some, why a patient may have a stroke. If the Pascal is unlikely, you continue your alternative stroke workup. If the Pascal is possible or probable cause of stroke as the PFO, then, and you've ruled out other etiology, then you consider PFO closure. So this is the national protocol that we have rolled out based on quite a bit of clinical data. We think that makes quite a bit of sense, and this has been vetted by our cardiology and vascular neurology teams. We know the Pascal score is very important because if the patient has an unlikely related PFO for stroke, we know not only is there no benefit of closure, but the risk of actually hurting the patient goes up if you close the PFO. We know that if it is a possible link between the PFO and the stroke based on the Pascal score in this category or this category, that the relative risk actually favors closure. And if it's probable, the relative risk reduction is about 90%. So, but this is very important because if you have a small PFO, because the size of the PFO, say they don't have a septal aneurysm, and say the PFO is large, okay? So there's a high structural risk. Even though the Robe scale score is low, going from a small PFO, which you may see on the echo, to a large PFO, which where you're much more likely, we showed, to find with the TCD, that will shift it from an unlikely to a possible PFO stroke relationship. And that can turn the tide and make you want to close the PFO. So you can see how critical it is here to not only find the PFO, but to get the sizing right. And we know now that robotic TCD is much more able to do that than echocardiogram itself. Now, let's turn to a second for finances. This is the world that we live in these days. So there's two aspects of robotic TCD finances. One is the TCD itself. Of course, there's a technical fee of doing the TCD. There's an interpretation for doing it on the part of the physicians. And there's a number of different studies. While you can do a bubble study, which is a 93893 code, you can do just embolic monitoring study itself, where you put the robotic device on and you monitor. We'll typically monitor for an hour or two. Some people monitor for 20 minutes or more. You can actually bill for this study and then go ahead and do this study. You can also do limited studies with the TCD, or you can do, here is if you do a complete study, you can see what the Medicare reimbursements are. And in many cases, what we'll do, as you can see on the right, is we will bundle payments, because we'll do a bubble study, embolic monitoring for someone when they first come in. It's, I think, very interesting. For example, someone comes in, it looks very suspicious. You put the robotic TCD on and you see that they're continuing to have emboli to the brain. Now, I'm not going to tell you that we know how to handle all those patients, frankly, but we use this in all sorts of situations with carotid dissections. It does help us, we believe, find embolic sources on patients when we see ongoing emboli in this patient population. From a national level, we have looked very, very closely at our reimbursements on PFO closure. And the bottom line is, as you well know, the reimbursement for PFO closure is really very good. Here are some national numbers. What I can tell you is it depends a whole lot on what's called the hospital base rate. The hospital base rate is a base rate that Medicare assigns to every hospital every year, okay? And that hospital base rate depends on, are you a rural hospital? Do you serve an indigent population? Are you a trauma center? Are you an educational center? But nonetheless, when we looked at all of our hospitals across the nation, the reimbursement on the PFO closure side is really very, very good. This is what our PFO closure rates have done over the last couple of years since we introduced robotic transcranial Doppler. And the bottom line is, I'm married to a cardiologist. Cardiologists are very conservative in their thinking. When I really knew that we were onto something good here is when I started seeing the cardiologist ordering as many robotic TCDs as I order out of my stroke clinic. So, and that's really driven. We have a very integrated program between neurology and cardiology here, great relationship. And we vet these patients very thoroughly for AFib and every other potential cause in our stroke clinic before we go closing anybody's PFO. Now, if you're 19 years old, like the patient I just admitted yesterday, who's got multiple emboli in his head, we're probably not going to monitor him for AFib for 6 months. We're probably going to monitor him for a short period of time and then close his grade 5 PFO. We're also very curious to see if he's got a hypercoagulable state. So in many cases, we have technologies that we do not have good financial support for because the reimbursements are very bad. We have things that pay a lot that don't work that well. The way I see this technology and the way we went after a national determination and contract very aggressively with our healthcare system with this company is because we see this as a win-win-win. It's a huge win for the patients, and it's a huge win for the docs, and it's a huge win for the hospital. And we love when all the stars are aligned. And that's really what we see here. So I can't share with you our actual finances, but it's a very impactful technology, and our CFO is very in favor of it. So there's numerous guidelines now that are published showing the benefit of TCD. You guys know that. It's really a matter of we now have a technology that frankly allows me to feel like for the first time I'm doing the right thing for my patients, which is fully evaluating them, and really it's solving a question that I've had for years that has really bothered me, is why have so many of my patients had strokes at a relatively young age, and we've never really found the reason why. I've had multiple patients now, negative echoes, we found their PFOs, and then we went on to close them. And that's a really cool story. And it's this partnership between clinicians and industry, and supporting our industry partners, and really getting the clinical data. We're very clinical trial focused, and we're interested not just in single center studies, we're interested in multi-center studies. And I think that the time is right now to do exactly what we've done, which is to include robotic TCD into our national healthcare protocols.
Fantastic. Thank you, Dr. Devlin. Can you hear me, by the way?
Hear you well.
Wonderful. Well, we're going to get some questions rolling in. So one question I also get people who message me directly. So whenever that happens, I assume that they just want to be anonymous. We have a few questions in the chat. I'll bring them up in a second. But one of the questions that I got was, from a clinician out of Nebraska. So looking out at your 2025 quality improvement data, when comparing it to the 2023 bubble trial, what were the findings that in your mind stood out the most in terms of clinical impact and maybe even diagnostic nuance?
That's a great question. Yeah. First of all, it validated the results from the industry trial. This is a completely independent trial that we did. It had nothing to do with the company, funded by our own private nonprofit that we have. First of all, I would have liked to have seen 3 times. The fact that it was, you really have to believe your data. And what I loved about it was that overall it was 1.6. What really stood out to me was the 1.9 number. So if you go back to our data in bubble QI, okay, it was this 1.9 number. So what we're saying is that this is the large shunts. Robotic transcranial Doppler is really twice as good at finding a Spencer grade 3, and these are the ones we'll often close, right? We're more likely to close the larger shunts, although we close some smaller shunts as well. But when I saw this number, this made a world of sense to me. And I like the fact that it wasn't 3, because I think it really tells the story. It tells the story. I know we have really good echo techs because we've got a really big, very academically focused cardiology group. And I used to own an ultrasound company years ago. I know my wife's a cardiologist. I know what good echo techs are. I know these people. So when I looked at that, I'm going like, while it's not 3, it's hugely better than transthoracic echo. And I know the guys that are reading the studies, the cardiologists, are really good at reading echo because they're all fellowship trained, specifically level 3 trained people that read the echoes. So that's a gigantic number more PFOs that we're detecting. And when I saw patient after patient after patient, what I loved about this data was this data doesn't lie. It's black and white. It's in your face. When you see negative echo, negative echo, negative echo, and then grade 5 PFO, and then you find it with the transesophageal echo, you can't hide behind anything. You can't wave your hands and say, well, this is because of this, that, or the other thing. And then over the period of about a year and a half, I saw the cardiology people completely come around. So that's how I would answer that question.
Great. You know what? And on is we have a bunch of other questions I want to roll through. So one of them actually, so Dr. K over on LinkedIn, I'm just going to bring this up and read. So great presentation, Dr. Devlin. Does TCD complement or replace TTE/TEE in cardiology workflow?
Yeah. So the critical thing here is not to talk about one technology over the other. Okay. We need all 3 working together. Okay. And let me go back right here. you always need to start with the transthoracic echo for the reasons I just said. You always start with it. And if you find a large PFO when they do the bubble study, you don't need to do the TCD, okay? Because you have to look for, as I mentioned, you've got to look for other sources of emboli. They may have a big clot in their left ventricle. They may have, endocarditis. They may have, which can be obvious sometimes on transthoracic. They may have a big tumor in their heart. They may have some other major problem. They may have an EF of 15%. So you got to start with the transthoracic echo, and we'll usually do a bubble study. Now, some centers forego the bubble study on the transthoracic echo and just do a regular transthoracic echo, and then everybody gets a robotic TCD with a bubble study. We actually start with the bubble study here, and if it's positive and it's big, then we don't need the transcranial Doppler. And then you always need the transesophageal echo. But I'll tell you, if the TT echo is negative and the robotic TCD is negative, okay, we normally do not do a transesophageal echo unless we're looking for something else. If you're looking for something like you need to get a really good look at the aortic arch, for example, if you're really worried about endocarditis and get a better look at a valve, but a really good transthoracic echo and a really good robotic TCD, that alone, we will not go doing a transesophageal echo looking for a PFO because we know you can't Valsalva with that. We have found, I think, one case in a couple of years where the TEE showed a positive PFO where it was missed on both of these studies. It's rare as hen's teeth. So the key thing is to understand the critical role of all three of these.
Got it. Understood. And actually, let me come back to you. We have another question from a Dr. Said Ansari. So the question he had, I had him clarify earlier was, and I like this question. It's like, who runs the neurovascular lab? Is it neurology or vascular surgery?
Yeah, that's a great question. Boy, that's a hot topic, isn't it?
I know. Do you know why I love this? Is because the positive side of medicine is that we're seeing convergence of a lot of specialties due to technology and innovation. But then there's also this confusion of like who essentially owns what part of the patient journey, who owns what on the department side. So there is a lot of like politics that's involved. I think a lot of people don't want to talk about it, but I think it's important we talk about it. So what's your answer to that question?
Yeah, that's a great question. Okay, so the answer is, so I oversee not only neurology nationally, but the neuro collaborative that I run also has neurosurgery folded into it. And in my institution, in our institute, a lot of us are going towards an institute model. You got neurology and neurosurgery all under one banner. The bottom line is everybody does it differently. And that's okay, as long as you do a good job. Okay. So for example, in our lab, all the TCDs are done in the echo lab. I've not fought that battle. I've not pulled TCD into my own. So I have a stroke clinic right down the hall from the cardiology clinic. And we're back and forth talking all the time about these patients. A lot of times we'll see patients on the same day. They do the echo sonography, people do the TCD. Now, when we did the bubble study, I will tell you, when we did the bubble QI study, it was my research coordinators that are not nurses and were not ultrasound techs at all that did all the ultrasound, because the robotic TCD, you can literally train your 15-year-old kid to do this and they would do a really good job at it. You don't need to have any training on ultrasound to use the robotic system. That's one of the reasons we like it. Now, in a lot of clinics, for example, other stroke clinics, they've got their own TCD in the clinic, and it's their secretary, it's their nurse, it's their MA that may be running it in the stroke clinic. The critical thing is we have the most important thing here is around stroke. you've got endovascular neurosurgeons, you've got vascular neurologists, you've got regular neurologists, you got cardiologists, all managing these patients. And I'll tell you, we published a really big paper in from Medtronic study, big international paper, and we showed that we are doing a horrendous job nationally in working up our stroke patients. Not only are they not getting this sort of thoughtful analysis, the vast majority of patients that come in with embolic stroke, are they even getting any sort of long-term monitoring whatsoever? That was called the DIVERT study, and I'm happy to send you that paper. So the critical thing is, when you are following a patient with a cryptogenic stroke, somebody that is managing the patient really needs to understand this entire diagram, which is why in our healthcare system, we have put so much attention on getting everybody to understand this. You've got nurse practitioners in many cases managing all of these patients. In about, I want to say 15 states in the United States, nurse practitioners are allowed to see patients completely independently from physicians with zero oversight, managing patients going through this pathway. And some of them do a great job. Some of them don't do such a great job. A lot of doctors don't do a great job. We know nationally that the vast majority of patients that could have cryptogenic stroke with AFib, they're not getting long-term monitoring, let alone are they getting this sort of thoughtful analysis. So all I would say is it doesn't matter who's working them up or who's actually running it. We got a whole bunch of endovascular neurologists that really just care about doing thrombectomies and aren't doing a great job working these patients up. They don't want to be in the stroke clinic. They just want to be doing thrombectomy procedures. And that's not what our patients need.
I'm really happy that you pointed that out. And I'm wondering, just like from a cultural standpoint, because I think like every specialty has its own culture and personality and everything. Like, why do you think that is, that, you know, that they don't want it, that they want to just be doing procedures and not doing the follow-up? Is it a training issue? Is it a reimbursement issue? Like, why do you think that is? And how do we solve that?
Well, I'd love to ask your audience that question. I'd love to hear what their thoughts. Our perspective, very simply, is represented right here in this slide, which is one of the biggest challenges we face in all of medicine is properly diagnosing final stroke etiology. The bottom line is, one, people follow the money. Working in the clinic is hard. Post-COVID, it's gotten 10 times harder. At our institution, they just closed the endocrinology office and they closed the rheumatology office. Okay, that is the future. The doctors are getting replaced by nurse practitioners in a lot of cases, and we employ about 20 nurse practitioners. Don't get me wrong, can't get through a day without them. But, you know, doctors are going, they like the procedures. They like doing the really sexy interventional stuff, which is great. But working in the clinic day after day, doing this sort of work with this sort of thoughtful analysis is really, really hard work, because, you know, it's, you know, we live in the world of EMR. You know, let me ask you guys, how many, what does your inbox look like at the end of a day? It's a very nasty thing to see, you know, more and more patients during the day and then have to come home and answer your inbox. So, you know, this is largely outpatient stroke workup. And my son is applying to cardiology fellowship programs right now. And, you know, we're talking about, what does the future of medicine look like? What do you want your life to be like? All I can tell you is we need really good, well-trained stroke neurologists. And the other thing is, if you look at the stroke fellows that are coming out of fellowship training, for the last 10 years, the emphasis has been on reading CTAs and MRAs, and very few of them are getting trained in ultrasound. Very few of these people. I interview 1,000 fellows every year, and I'll tell you, very few of them are coming out of programs where they actually get hands-on training, which means they don't understand the benefit of transcranial Doppler ultrasound because it's a different way of looking at the brain, and it gives you this information we get from TCD is very complementary to CTA. We love CTA, but you can have a very normal looking CTA with essentially no flow in the artery, and even the CT perfusion can look very good. And we've learned that lesson by spending so many hours in the operating room looking at TCD on patients having open heart surgery.
Got it. We have another question in the comment section. I have another question myself, but I'm going to go back to Dr. Ansari. There's a good one. Is there any comparison between RA-TCD and conventional TCD method from a sensitivity standpoint?
Yeah, so that's been studied, and that's a great question for Dr. Robert Hamilton, who is the CEO of NeuroSignal. That has been studied, it's been published, and it was looked at in the original bubble study. And what they found were multiple cases where the robotic system, and this has been our experience as well, because we do both here, the robotic is much more likely to find the artery and stay locked onto the artery. So, for example, so there's two things going on here. First of all, it's much better at penetrating the bone windows than the handheld unit. We do much better at our success rate of TCD is much higher with the robot. That's what we found in the manual, number one. Number two, it's a whole lot easier to stay locked on to the artery. And that's why we think, and I mentioned, I think in the bubble study, it's published twice as many, it was 2 times the number of right to left shunts detected with the robot than manually with the handheld probe. And I did show that slide. So this has been compared, and we can get you that data. That's a very good question. It's a very important point. You know, there's all these servos in the robotic system. So when it locks onto the middle cerebral artery, the patient head continues to move. And as the patient's head continues to move, and we've actually even studied this in an ambulance as that head is bouncing around, it will stay absolutely locked on to the MCA, because what you'll hear is these little servos going zit, 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 and they're making every second, or sometimes multiple times a second, they're making fine adjustments to stay locked on to the middle cerebral artery territory. So it's really not surprising that that the robotic system is better.
Got it.
We can get you some references. If you send us your email, we'll send you some references on that.
Yeah, and then Dr. Ansari, I'm going to have Dr. Hamilton also follow up with you.
So here's the bubble trial. This is the original bubble trial. NGT outperformed manual TCD 2 times. That's a very important question. Why is the robot better than the manual system? This is exactly the benefit of that. And keep in mind, this is extremely dependent on your ultrasound techs to do the manual TCD properly. And that, I think, has a lot to do with why it performs so much better.
And, you know, I want to jump in and kind of comment, just as, like for me, a lot of my career is built in robotics. I think this is the important side of really good hardware, where things that are normally manual should not be manual. And so if you have somebody who's highly trained as a clinician, most of their time should be spent on analysis, interpretation, follow-up, etc., and not like performing the manual side of these things. Even I would say, if you go even to surgeries, a lot of the manual stuff and surgeries and the procedures are going to get commoditized. And so for clinicians, I feel like if we want to get really futuristic and scope out 50 years from now, a lot of this stuff will be done automatically with hardware, software, and clinicians are going to be spending more time on, you know, data interpretation, using AI, clinical outcomes, clinical decision making, et cetera, and not, you know, trying to spend God knows how many hours in fellowship and training to perfect like a manual technique. Would you agree with that? Dr.
We're
Devlin?
100%. I think that's a great point. We need our stroke neurologists to think about this chart. We need their brains to be about. I mean, there's well over 100 different causes of stroke, and they need to be up in the literature on exactly how to treat these things, because this is really complicated. All the data on dual antiplatelet therapy and what to do with their lipids and everything else like that. We need the doctors to be thinking about this algorithm and be thinking about this algorithm and making sure their patients follow through this completely, and that we get closure at the end of the cryptogenic stroke workup. Okay.
Yeah.
We're doing a terrible job on that, but we'll never do a good job unless we properly identify the PFO. And, doing PFO work is not like reading EEG. Now, I spent a lot of time as a neurointensivist reading EEG, okay, and I love EEG, but there's a lot of disagreement about, is this ictal or is this not an ictal sharp wave? And the bottom line there is a grade 5 right to left shunt is a grade 5 left to right shunt. Either you don't find it or you find it, and you can quantitate it really nicely. And once you have the data in your hand, which is what this technology gives us, then we know we can figure out pretty quickly what to do about it. And what's so exciting is PFO closure is a very easy procedure. It seems, with all of the trials we have, it's a pretty darn safe procedure when done well in good hands. And it clearly has a pretty robust benefit in the properly selected patients. But with this technology, not only can find PFOs, we can find the big PFOs, which are more likely to have a benefit. And with the proper Pascal score, now you can have the proper conversation of risk-benefit analysis, because that's what the Pascal score offers you. But without the TCD, you don't have that data to have that conversation with.
Absolutely. And I think we're still in the very early phases of it. I think in businesses like mine and other places, you'll see the adoption of AI, but obviously that's not going to happen right away in medicine, because if it makes a mistake in my business, like we were talking about, like an operations thing, and in medicine, like you're talking about a human life. But as I think AI starts to get rolled out, I think the other side of it is that clinicians are trained on the nuance. And so I think even these algorithms you're sharing, I think AI can do a large majority of the guidance, but the clinician is going to be trained on specific nuances that sometimes, LLMs and machine learning and AI are just not adept to doing. I don't think they will be for a long time, but we'll see. I got one. I want to be very mindful of your time, Dr. Devlin. For those who are watching, get your questions in. If you have anything else, if we run out of time, we'll follow up with you. But you mentioned about the importance that reading a PFO is very different from an EEG. I believe you mentioned that early, correct?
Yes.
So my question is, if you kind of scope out, let's say beyond PFO detection, what do you feel like is sort of the emerging role for robotic TCD, sort of in let's say a broader stroke risk stratification, specifically, let's say outpatient neurology or in clinic settings? Where do you see that going?
So we spent a lot of time studying this. That's a great question. It's a great place to end. I'm very, very excited about that. This is a quickly emerging field. Medicine in 10 years from now is going to be completely different. We do a lot of work in AI. We launched VIS. We were the center first in the world to identify a large vessel occlusion using AI. The bottom line there is there's two places which are going to be gigantic. Number one, we don't have an EKG for the brain. We do not have a good pre-hospital diagnostic for large vessel occlusion strokes, okay? And there is not a more time-sensitive condition in all of medicine than stroke, okay? And there is no good pre-hospital scale. You can look at RACE and LAMS. None of them are particularly good. There's a lot of technologies trying to be LVO detection technologies for an ambulance, but whoever comes up with something on the ambulance or on the helicopter that can identify a large vessel occlusion stroke, and you know there's a lot of technologies floating around, but none better than looking at the M1. And what's so interesting, we published a paper about this. It's not just looking at, PFO is very simple. There's bubbles, there's no bubbles. But using AI, we can look at the very, very subtle changes in the waveform. So you can have a clot on the left side in an M2 of your brain, and it will change the waveform pattern of the blood flow in the M3 on your right hemisphere. Okay. And it's subtle. You're not just looking at the peak systolic and the peak diastolic velocities or anything like that, or the pulsatility index. You're looking at the overall curvature of the waveform. So with the robotic TCD, okay, and we're already studying this on ambulances. We put a lot of time and effort into that. That is where robotic TCD is going, number one. Number two, we get it for an ambulance. You're going to have it in the hospital. If you think about two scenarios, the operating room during open heart surgery, carotid surgery, etc., the neurointensive care unit. Think about all the things we monitor in a cardiac operating room, okay? We monitor everything possible, but we don't monitor the most important thing, which is cerebral blood flow. So we have spent a god-awful amount of time with the robotic TCD on the head of patients having cardiac monitoring during open heart surgery. And what we find, for example, is that the mean arterial pressure or the pump pressure when the patient goes on pump, you think the pump pressure is adequate, but in many cases, it's not adequate at all. So we've actually brought patients in, dropped their mean arterial pressure by about 10 after they are intubated, okay, at the beginning of the heart bypass procedure, and they lose complete blood flow to one side of the whole hemisphere, okay? Somebody that has an intracranial stenosis, we found that on. And it's very, very easy for us to just say to the anesthesiologist, hey, turn up the pump pressure, right? Turn up the pump pressure, and then we can follow. Now, we're looking at velocities on the TCD, but velocities, it turns out, is a very good surrogate for blood flow in the brain. And when you turn up the pump pressure, you can regain the normal waveform. It's very easy to see. Now, if you want to make an anesthesiologist mad, get your TCD tech in the operating room at the head of the patient's bed with the anesthesiologist. Because what's the anesthesiologist? What is he going to say to you? He's going to say, I'm the echo guy in the room. I'm the guy that is raising the blood pressure and lowering the blood pressure, okay, because I can dial it up, I can dial it down. I'm the one managing the transesophageal echo. I'm the ultrasound guy. Why are you even in my space? And you're in my 4x4 space, by the way, doing the robotic TCD. Now, in the past, we tried to do manual TCD on patients having open heart surgery, but it turns out that when you put a manual headset of a TCD on a patient having open heart surgery, their head is moving all around and you're losing signal continually. It doesn't stay on for more than a minute and you lose the signal. But with the robotic TCD, you put it on and it just stays locked in there. So just as it would in somebody that has a thrombectomy and you want to continue to monitor their brain flow in a neuro ICU, even though they're moving around, the robotic TCD. So the applications, the other applications for this technology are immense. And I think it probably has the best chance because it's relatively inexpensive. And keep in mind, what don't we have on helicopters? We don't have stethoscopes on helicopters. Why don't we have stethoscopes on helicopters? Because they can't hear anything. What do they have on helicopters? They have a lot of ultrasound equipment so they can ultrasound the body every which way and see what's going on. Robotic TCD really lends itself for helicopter use as well as ambulance use. And you can't do an NIH stroke scale score on somebody and figure out if they have a large vessel occlusion. We've looked at that. You can have an NIH stroke scale score of 1 and still have a large vessel occlusion. But the robotic TCD would tell you that. So in summary, the applications of these robot devices are immense. What's going to happen in the next 5, 10, 15, 20 years in my son's generation of being a doctor is going to be unbelievable, hard to predict. But I think we're launching this with PFO, and we're well on our way to finding a whole bunch of other applications. And I'm sure a lot of people in the audience here are very excited about those things. I'm sure there's a lot of people here that could give us an independent lecture on a lot of those topics too.
That's fantastic. Dr. Devlin, I know we're way over time. I got like one more question for you because it's a really interesting clinical question. It was sent in anonymously. So here's a situation clinically. If your TT is negative, but your TCD is positive and the TEE is negative, what's your course of action?
So here's what I would recommend everybody do. You really got to get this paper. We spent a lot of time writing this paper. In this paper, we have not only our data, but we spent a lot of time in the discussion section explaining this entire diagram. Okay, this diagram is your blueprint for answering all of those clinical questions, and I've got all the references. So what you asked, I believe, is your transthoracic echo is negative. Your TCD is positive, right? So you go to TEE, but your TEE is negative, right? Then the question is, what do you do? Right? That's what you just asked.
That's correct.
Okay, well, where do you go? If you go to the diagram, it's right there. Where do you go? You go to ICE. So if the TEE is negative, even though the TCD is positive, but you have a high clinical suspicion for a PFO, then you got to get your cardiologist on board. And I have a wonderful video of my cardiologist, Dr. Sam Ledford, very bright guy, explaining exactly that scenario. He had exactly this scenario. And based on the experience that he had, because 3 years ago, he never would have done this. He's got so much faith in TCD now because we saw it. We injected the bubbles. We saw it up in the head very, very quickly. He took the patient and did ICE. And then he actually took a metal probe, right, like a pencil, was in the atrium and actually mechanically found and opened up a large PFO and then went on to close it. So the answer is you're going to run into those situations because if the sensitivity of TCD we're saying is higher than transthoracic and higher than TEE, you're going to find exactly that patient that you asked a question about, and you're going to want to take those patients. You want to, it could be a pulmonary shunt. It could be a pulmonary level shunt, but particularly if you see it very quickly within a couple cardiac cycles, okay, it may well be a situation where when you get in and you cath the patient, you actually can find it very easily, and it's a probe patent PFO, and you can find it with intracardiac echo pretty easily. That's the answer to that question. I would strongly encourage everybody to pull that paper, and that is the bubble. It's this paper right here. It's the Bubble QI paper, and we can send you the reference. Okay, it's this study right here, Bubble QI. Just type in trans. It's very easy to find. Dr. Shah, S-H-A-H. Dr. Rashir Shah, S-H-A-H. First name Rashir, R-U-C-H-I-R. Published in Frontiers. Frontier Stroke, it was published. 2024. Just put in transcranial Doppler, Rashir Shah, you'll pull it up. It's got a very extensive discussion that should answer a lot of other questions that may be out there.
Fantastic. And for those who are, if you're watching this on replay now, you can just go ahead and comment in the comments below. If you're interested in that study, we'll get that over to you. Dr. Devlin, look, thank you for spending so much time with us. We really appreciate it, especially at the end of your clinic, I called you earlier and you're finishing up with patients. So we really appreciate your time. I want to thank the audience for watching. If you have a question, again, even if you're watching this on replay, go ahead and drop in the comments. If you want to learn more, go to neurosignal.com to learn more. And with that being said, we hope you all have a wonderful evening. Take care.
Thank you very much.
Thanks for checking out this episode. If you want to do me a big favor and join so many other people who have helped grow this podcast, take a second and look below. If you're on Apple, give us 5 stars and write a short review. If you're on Spotify, just give us 5 stars. And if you're on YouTube, hit the like button. And most importantly, if you can, subscribe. We release so many different episodes that you may miss. Be sure to subscribe and turn your notifications on. You get extra points with me if you subscribe across all 3 channels. Thank you so much. And if you felt like this episode helped you, send this to somebody who would really enjoy and appreciate it. Share and spread the love. We'll see you all next time.